Okay. Good afternoon, everyone. Thank you very much for joining us today. Same as always, we encourage everyone to keep their video on, as definitely it adds to the sense of community. And it would be wonderful to see you today in this afternoon. Welcome to the next lecture in the MAHSC Inaugural Lecture Series, which celebrates the remarkable contributions of our honorary MAHSC clinical chairs. So these honorary chairs are awarded annually by the Promotions Committee of the University of Manchester's Faculty of Biology, Medicine and Health to distinguished individuals across Greater Manchester. Each honoree has made significant contributions to their clinical specialty, demonstrating excellence in research, education, and clinical practice. Today, we are so pleased to welcome Professor Agata Rembielak from the School of Medical Sciences, Division of Cancer Sciences. And now I will hand it over to Professor Joe Hart from the school to give the introduction. Thank you so much.
Good afternoon, everyone. It's my absolute pleasure. Good afternoon, everyone. It's my absolute pleasure to introduce Professor Agata Rembielak. As Yasmin said, Agata has been awarded one of our highest honours in the university, which is a MAHSC chair. And what that means for us is very important. Our work in the community with our patients is of incredible importance to us and value to our local communities in the university. And Agata is a brilliant example of someone who has contributed so significantly to her clinical specialty that she's become one of very few MAHSC chairs that we have in the university. Agata started her clinical oncology career in Poland, training there and working clinically alongside fellowships and her doctorate in Poland, but also in Australia and Canada. So we're really, really fortunate that she chose to make the UK her home, moved to the Christie in 2007, and has been with us ever since. Her clinical and research work in skin cancer, radiotherapy, many important associated areas, means that she's invited to author important guidance, patient support work, journal editorship, and multiple prestigious speaking invitations. Alongside all of this, she is an active and excellent educator, finding time to support and teach education locally, in her professional bodies, and even internationally. Agata, we're very much looking forward to hearing from you. Over to you.
Thank you very much. And I would like to thank for inviting me to give this inaugural lecture. And I cannot stress more how privileged I am that I was recognized and awarded by the University of Manchester and with the honorary clinical chair. As Joe mentioned, my journey has been so far across the whole globe. So in today's lecture, we will be traveling a lot as well. But I'm going to start, if I can move computer slide. Is it visible now, the quote? So I'm going to start with a quote from Maria Skłodowska-Curie, who was Polish. And we are all very proud of her, and we are all aware about her contribution to radiation and chemistry and physics, saying that nothing in life is to be feared, it is only to be understood. Now is the time to understand more so that we may fear less. And I'm going to start with 1986. This is Poland, Chernobyl, where we all were unfortunately exposed to radioactivity. And you can see people queuing in Poland, in local school, to get a Lugol solution, which was definitely for many provided too late. But there was really a lot of fear, a lot of misunderstanding. And I was there as a small child, but I was really curious what is happening or what happened and why people are so feared of something that we couldn't see. And In addition to this experience with Chernobyl disaster, I used to live in Gliwice, which is in southern part of Poland, and we are very lucky in my home city to have a branch of our National Cancer Institute in Poland. And this institute is was named after Maria Skłodowska-Curie, and she donated 1 gram of radium to the institute. Therefore, it was possible for people to be treated using radium many years ago. There is a big branch of this National Institute in Warsaw, and not far from Gliwice in Krakow, only 3 branches. Moving forward, when I completed my medical study in Poland at Medical University of Silesia, it was almost inevitable for me to consider any specialty involving radiotherapy. So it was radiology or radiotherapy or nuclear medicine. And at that time, I remember my involvement in student association and multiple projects, including and leading conference presentations, and radiotherapy caught my attention. And this is what I decided to do and what I've been doing ever since. But it's not only medicine. I was allowed by our dean to study concurrently medical physics. And again, it is all about understanding of radiation and having this support from medical physics knowledge. My dissertation was in comparison of different treatment planning systems in radiotherapy. We are now moving fast forward. I'm now moving to Melbourne, where in 2000 I was very lucky to have a clinical research fellowship. And the main reason for this fellowship was to learn about new, at that time, radiotherapy technology called IMRT. For those who may be less familiar with radiotherapy terminology, IMRT is an abbreviation from intensity modulated radiotherapy, and it is about providing very precise radiation using a multi-leaf collimator, so leaves, as you can see on the upper right corner, which can move during radiotherapy. Therefore, we can provide very precise radiation to the cancer while saving and sparing surrounding tissues. In 2000, it was really a very, very new technology. And following my fellowship, I was involved in a team in my home country, Gliwice, where we had first application of IMRT in Poland, and it was in patient with prostate cancer. I also used my knowledge and skills in conformal radiotherapy in those new technologies, allowing me to complete my PhD in 2003, again in Poland. So we are moving now to a further part of my professional development. This time it is Toronto. So I was awarded clinical research fellowship in Toronto, Sunnybrook Hospital, where the main reason for this fellowship was to learn about brachytherapy, specifically in prostate cancer. Now, again, for those who may be less familiar with radiotherapy terms, brachytherapy is a way where we provide radiation very, very close to the tumor, and you can put radiation almost directly over tumor, for example, in skin cancers, or you can use as an insertion, for example, into prostate. I met lovely friends and colleagues from, it was more than 20 years ago, almost now. We are still in touch and we are still cooperating at professional, but also like a social level. These are examples of brachytherapy. So I mentioned you can put it on the skin, for example, in ear cancer, but you can also insert needles and radiation into areas if infiltration, for example, is deeper. So as a result of my fellowship, I was involved again in a first application of prostate brachytherapy in Poland, in my home country again, in my home city again in Gliwice. But also, I have to say that we provided first world application of intraluminal brachytherapy in renal artery to prevent restenosis. And that's a little bit outside oncology, but radiation can be also used for benign conditions. And this is one of the examples that I've been involved. Following my fellowships, I was invited for an interview in Manchester, and this is where my Manchester story starts. I started as again, clinical research fellow at the University of Manchester, working clinically at the Christie Hospital. And it was planned initially for 2 years. But after completion of my MD in research on combined radiotherapy and systemic treatment, I started working at the Christie. And again, this world first would appear several times, but in 2010, we opened first networked satellite center in the UK at the Christie at Oldham. And this is where I have half of my time shared between Christie in Withington and Christie at Oldham. On the top of it, I got a position of clinical oncology consultant with special interest in skin and palliative radiotherapy. And again, that was this combination in clinical oncology subspecialty in the UK. So what I am currently involved in is in palliative radiotherapy. We have set up a rapid access palliative radiotherapy clinic at the Christie at Oldham. And this is the way how we can provide this very important treatment to help our patients in very timely manner. We can reduce waiting times. Patients can be seen same day, planned and treated same day if required. And this is important, especially for patients in palliative situations where terminal cancers, well, definitely the one thing that they wouldn't have is time. And this is Christie at Oldham. We are based at the Royal Oldham Hospital premises, and this is where we provide this service for our patients. This is just an example in terms of going through referrals. So as for rapid access, more than 80% of our referrals are urgent, so requiring us to treat patients as soon as possible. And 3% would fall into category of emergency. And the example could be, for example, metastatic spinal cord compression. And this is just another example when we did audit of our work at the Christie at Oldham in rapid access clinic, where we looked into how many patients are treated within time frame from referral received and to start radiotherapy. And again, for those who may not be very familiar with radiotherapy, before we even start radiation, we need to review patients, obviously discuss consent. Then for radiotherapy, then there is a usually planning scan involving CT scan. Then we have to plan their treatment and then we can treat. So it's not often possible, especially for radical patients, to start treatment immediately within 24 hours. Sometimes it's a few days of planning. But for palliative radiotherapy, we've managed to reduce this time for our patients. And it was really very nice what we've learned, not only from our colleagues and our patients and looking through rapid access clinic, that implementation of this clinic has achieved its intended benefit to provide really timely and efficient access to palliative radiotherapy for patients in our area. And we work within multidisciplinary team approach, and we are able to provide this patient-centered and holistic supportive care approach as well. While working at the Christie, I also completed my MA in clinical education at the Edge Hill University. And my thesis were on evaluation of a skin course, which I deliver at ESTRO. ESTRO is European Society of Therapeutic Radiotherapy and Oncology. The course, this is just an example of the course we have just delivered in October 2024. It was the 4th edition. It's an international course for international audience with international faculty, focused on non-melanoma skin cancer, which is the other part of my subspecialty. So in terms of skin radiotherapy, we can deliver it in both ways. We can deliver it as an external beam radiotherapy, and this is what people are usually familiar with, where the source of radiation is at certain distance from our patients, but we can deliver it also via brachytherapy. And this is when radiation in skin cancer is delivered directly onto the skin. And just an example that radiotherapy is very good alternative to surgery, especially for patients who may have lesions in the areas which are cosmetically or functionally sensitive. And it's very often used as an alternative to surgical management. This is example of brachytherapy, this time on hand in one of our patients. I'm really very proud working here in Manchester, which is known to deliver in late 30s a special system of brachytherapy called Manchester system. And at some point we compared our plans from our colleagues, which you can see on the left-hand side, with modern treatment planning system. And when you look into both plans, you can see that even without huge computer support, our senior colleagues many years ago were able to provide really very good plans and help patients while not having support we are having at the moment with computers and AI as well. These are pictures which actually were taken at the Christie. So they are taken in late 30s, 40s, and 50s, where brachytherapy was used. These are unique pictures, but I think as far as I'm aware, Christie Hospital is one of the unique hospitals in the whole world where we have a trace of continued delivery of brachytherapy in skin cancer since almost its inception. And this is something that we are very proud of, and we continue to deliver for the benefit of our patients. These are pictures just only to show that radiotherapy is not current radiotherapy is very modern. We use a lot of technology, lots of computers, but still we are able to obviously help patients in the best way we can. So what about Agata in 2025? I mentioned, and it was a huge, I'm really proud and grateful for recognition by the Manchester University to be appointed a chair. Royal College of Radiologists recognized me, awarding fellowship of Royal College of Radiologists, and this is huge achievement. You cannot become fellow of Royal College if you are not, if you haven't taken exams under Royal College. So this is recognition of my input into Royal College as I was trained outside. I work, as I mentioned, at ESTRO with our European and international colleagues. And I was really very proud to work with a very experienced group of people, leading to 2 publications on non-melanoma skin cancer and in radiotherapy, specifically in skin cancer. Currently, I'm involved as a co-CI in a clinical trial called SCC After. We have been awarded by NIHR, who's funding this trial. And this is for patients with high-risk skin cancer, subtype squamous cell cancer, and randomization is to radiotherapy versus clinical follow-up after surgery. And the reason for this trial is that we would like to know what's the role of radiotherapy in patients who underwent surgery and whether they require any further treatment to reduce risk of local recurrence. The trial has just been opened, so we are hopefully be able to recruit shortly our first patient. And I'm also involved at EORTC in quality of life work, where we are designing a health-related quality of life module for patients affected by skin cancer. At the moment, there is no such module in existence. So patients, for example, in clinical trials in skin cancer would need to complete several different modules. Some of them may not be very relevant to their treatment or to their disease. So we are hoping by developing this tool, we will help our patients to reduce number of tools they need to do. So in terms of summarizing my presentation, I would like to finish also with Maria Skłodowska-Curie, who said, "One never notices what has been done, one can only see what remains to be done." And I would like to dedicate this talk to my great friend, Dr. Wu, who's Australian, who was Australian radiation oncologist, very passionate about skin cancer, but unfortunately is not with us anymore. Thank you very much for your time.
Thank you so much. That was absolutely amazing, and how wonderful to hear how proud you are to be in Manchester, because we're really proud to have you. I loved the Manchester system all those years back and those photos that show that consistency of effort. I know that people have to rush off. If people have any questions, please raise your hand, but I thought I might start with a question while we have a little bit of time, if that's okay. I was really struck by some of the things, well, many of the things you were talking about, but I was thinking about your rapid access clinic for palliative radiotherapy, which seems so important for patients at a very difficult stage of their life. Is that something, when you think about your journey in Poland, in Canada, in Australia, is that something that you're able to then share those ideas and those models that other countries might do similar to the services you've set up?
So rapid access clinic in radiotherapy, it is not only UK concept. Actually, when I was in Canada, in Sunnybrook Hospital, this is the place where the first clinic was developed. And I think it was 1999 by Professor Ed Chow, and he's one of those people I presented on pictures. There are similar clinics across the whole globe. Every clinic is a little bit different depending on local needs, depending on group of patients. But I am in very, very close contact with other clinics and lead the people leading those clinics in order to exchange experience. And we learn from them, they learn from us. It's not that it's only Oldham patients. We are able to provide similar service, for example, via on-call team at the main Christie in Withington. So it's not that we deprive patients being in other areas of Manchester, but the fact that we have dedicated team and dedicated service, this is really very, very important for our patients.
Yeah, thank you. Jonathan, do you have a question? I think maybe Jonathan was clapping rather than asking a question. Any other questions that you can see, Yasmin? Oh, you have one.
So yeah, I can't see any other question, but if you don't mind, can I ask a very quick one?
Please do.
Yeah, so thank you so much, Agata. Thank you for just, sharing your amazing journey with us, and congratulations once more on your fantastic achievement. So I was just wondering, given your substantial role in research and clinical practice, considering all of the exams, traveling, journeys, how do you really balance these responsibilities and also your commitment? How do you manage them all?
This is always a challenge.
I know.
But you just learn as you go. It can be difficult, but again, my family, I have to say, is very supportive. So my husband and my daughter are supporting me. They understand the need. And when I needed to learn, I needed to learn. But finding balance is difficult. It's difficult. There are days when you feel guilty because you haven't done anything, or there are days you've done too much and you think about your family. But it's not the easiest way, especially I have to say for women.
Thank you, Agata. Really,
and
really...
I can only say it's about passion, and if we are passionate about something and if we believe in something, everything is possible.
Fabulous. Thank you so much, Agata.
Thank you.
Thank you very, very much.
So Jonathan has posted something on the chat. He can't ask a question because his microphone isn't working, but he's clearly interested in talking more about AI. So that would be a really good thing to talk more, as is on all of our minds at the moment. So if it's okay, I will close the session there and say thank you so much for your time. We can see how many exciting things you've got coming up and how many more things there are to come, as per your quote from Marie Curie about what remains to be done. So thank you for doing that in Manchester, and thank you for being willing to be part of this really prestigious appointment at the University of Manchester.
Thank you. The whole pleasure is mine. Thank you very much for having me today. Thank you.
Thank you, Agata, and congratulations again.
Thank you very much. Bye-bye. Bye.
Congratulations. Bye-bye.